Okay, so I'm just going to talk about ICCS terminology. I mean, terminology is a bit boring, but I think it's important and necessary. So the International Children's Continence Society decided to produce a document for standardisation of terminology of lower urinary tract function in children and adolescents. And the reason is because up to that time and even now, there's a lot of publications which talk about different things, and you don't really know whether they're talking about the same things or different things. So it's really difficult to compare things. People use different terms to mean different things. And so they've just decided to form this standardisation. It was first done in 2002, updated in 2006, and last updated last year. And the changes basically reflect in advanced knowledge in this field. And it's not perfect yet, but it's evolving. And so we will, in this whole day, be using ICCS standardised terminology. And when we write to you, hopefully we will use ICCS standardised terminology. And when you communicate with us, we talk about the same thing, it makes life much easier. So some common general terminology. Dysfunction means clinically significant and relevant. So some people might have daytime wetting, but it's not a dysfunction because it's just not a problem. So bladder bowel dysfunction means when a child has a combined bladder and bowel problem. It used to be called dysfunctional elimination syndrome, but that was a mouthful and didn't really mean anything. So now they've changed it to BBD. When does incontinence terminology apply? So for lower urinary tract dysfunction, it generally applies to children aged 5 or above, and that's because that's when they're usually toilet trained. And for bowel dysfunction, at age 4 and above. So lower urinary tract symptoms, let's see. So frequency, normal is really 4 to 7. So a child would have increased urinary frequency if they void 8 or more times per day, and reduced urinary frequency when they void 3 or less times per day. Incontinence is broken up into this lovely little graph, so this is urinary incontinence, if I can just talk through it. So incontinence is either continuous or intermittent. Continuous means they dribble wee all the time, and it's usually a neurogenic problem. Most of today, apart from the neurogenic talk, will not be in this space. We're really talking about this group. So of kids who have discrete episodes of incontinence, so intermittent incontinence, it's then broken down into daytime incontinence or enuresis, which is the same as night wetting or nocturnal enuresis or bed wetting. And in the enuresis space, it's broken down into monosymptomatic and non-monosymptomatic, and Dr. Day's going to talk about in a little while, so I won't discuss it further. But basically also just to point out there's primary problems, so kids who've always had the problem, or secondary problems where they develop it after being continent for at least 6 months. And so all of these categories are important because it points to etiology and management. And urgency means a sudden need to void, and nocturia means the need to wake up to pee. They don't necessarily need to wet, but they need to wake up to pee. So hesitancy is difficulty initiating voiding. Straining is needing to increase your intra-abdominal pressure to void. A weak stream is obvious. It can also be detected on a uroflow, which we'll show you later. Intermittency means that the urine stream stops and starts instead of being continuous, which is normal. And dysuria is pain or discomfort during voiding. So holding manoeuvres is observable strategies used to postpone voiding or suppress urgency. So often you'll see girls who put their heels on their perineum, boys who hold their penis. Often they're unconscious they're doing that, and often they don't realise that they need to pee at the time. It's associated with bladder overactivity. Feelings of incomplete bladder emptying or dysfunctional voiding means when they don't feel like they've completely emptied their bladder. Urinary retention means being unable to void when their bladder is fully distended. And post-micturition dribble is dribbling after they pee. And in girls, it could be a sign of vaginal reflux. And in both genders, it could be syringoceles. Spray of urine, particularly in boys, it's a spray or a split urine, and that could be a sign of meatal stenosis or obstruction. So you'll hear more about these from Annie Deshpande and also from Sukanya Day. And pain could be from bladder, urethra, genital area, including irritation to the skin and priapism. So tools of investigation, the non-invasive ones are the ones that we generally use a lot. So bladder diaries, again, you'll hear about that later. Questionnaires, psychological screening, urine flow measures, which we do at this hospital and I know some centres do. Ultrasounds, And invasive things include urodynamic studies and voiding cystometry, which the urologists do. And for infants, you can do a 4-hour voiding observation just to see what they do when they pee. So signs are looking at the voided volume and the urine output. So just a little bit more details. A bladder diary is a daytime frequency and voiding chart for at least 2 days. And we also ask for 7, or this is ICCS terminology, they also ask for 7 nights of incontinence episodes and nighttime urine volumes to determine the child's bladder function. It's important to document incontinent episodes, voiding frequency, urgency, voided volume and fluid intake, because that just gives you a lot of information about what's going on. So the lower urinary tract questionnaires, this is mainly for research, but there's a dysfunctional voiding symptoms score and a paediatric urinary incontinence quality of life score, which are standardised questionnaires that people use so that we're actually talking about the same thing. Psychological screening, incontinence is quite often associated with psychological conditions, and ICCS recommend using the Child Behaviour Checklist or the SSIPPE, which is a short screening instrument for psychological problems in enuresis, which is developed by ICCS. Ultrasounds are really helpful. We do ultrasounds quite a lot. So ultrasounds tell you post-void residual, and if it's more than 10 to 20 mils in a 7 to 12-year-old, it's likely to be abnormal. We also can look for thickened bladder wall, suggesting lower urinary tract dysfunction, rectal distension of greater than 3 centimetres, suggesting chronic constipation and fecal impaction, which I'll talk about later, and urine flow studies. And this is just a picture of what a urine flow study looks like, or a uroflow. So all the funny different shapes there mean different things. So a normal is a bell-shaped curve, which is A here. If you have overactive bladder, you might have a tower shape that sort of has a high pressure. In coordination of bladder sphincter with intermittent sphincter overactivity gives you this sort of staccato-shaped void where you can imagine the sphincters not coordinating with the bladder. And underactive bladder means they just need to push a number of times to get the pee out, and so that's an intermittent stream. And if there's bladder outlet obstruction or an underactive bladder, they have this flat plateau shape, sometimes even flatter than that. Sometimes it's almost like a flat line. So urodynamic studies, that's in the realm of the urologists. It can be done via transurethral or suprapubic catheters, and it can tell you more about the filling and empty phasing of bladder function, and sometimes it's done with EMG to actually see what muscles are happening, but I'm sure Ani will talk a bit more about that. So it can be used to assess sensation, involuntary detrusor contraction during bladder filling, bladder capacity, bladder compliance, urethral function, and leak points. So it's very complex, and not everybody gets this, but if you've got a kid we can't figure out, this really helps us know what's happening with the bladder. And some normal values. This is good for everyone. This is stuff you should know. So an expected bladder capacity, this is the number I use all the time. It's really helpful. It's for children aged 4 to 12 years. So the calculation is, like, it's rough, but 30 times the age plus 1 in mils. So if you've got a 10-year-old, it'll be 30 times 11, 330. That would be what their expected bladder capacity should be for a child their age. And if it's not, that would suggest there may be a problem. So a maximum voided volume is there. You get them to do a time and volume chart. You see what their biggest wee is during the day, excluding the first morning void, because that is allowed to be a little bit larger. And if their maximum voided volume, so if their biggest wee during the day is less than 65% of this EBC, they have a small bladder. And if it's larger than 150% of EBC, they have a large bladder. So that just is very helpful to know what's going on. So polyuria is if their voided volume is more than 40 mils per kilo per day, obviously depending on what they drink, but that's a good ballpark figure to work with. And nocturnal polyuria, so we look for nocturnal polyuria in kids with nocturnal enuresis. Are they making too much pee? The formula is 130% of the expected bladder capacity, again, a little bit dependent on what they drink. So symptoms and conditions. So conditions of enuresis or daytime urinary incontinence are relevant in children over 5 years when they have more than one episode a month, when it's going on for 3 months or longer, and they're called frequent if they have it 4 or more times a week, and infrequent if they're less than 4 times per week. And if it's less than once a month, we'd probably say it's not really that important. And symptoms and conditions, enuresis is both a symptom and a condition, and Tanya will talk about these later. And the symptoms of daytime urinary incontinence can be caused by many different conditions, and I'm sure she'll talk about that later as well, and this is some of the conditions I'm sure she'll talk about. So comorbid conditions associated with lower urinary tract. So constipation and fecal incontinence is quite relevant, and it's often associated with lower urinary tract function. Urinary tract infections, obviously, and asymptomatic bacteriuria, which is a form of a urinary tract infection, vesicoureteric reflux, and neuropsychiatric conditions, in particular ADHD, ODD, depression and anxiety disorders, intellectual disability and disorders of sleep, and obesity. So these are the things identified by ICCS, but certainly we see them all the time as well. So the sorts of treatments ICCS talk about are broken into pharmacological, surgical, neuromodulation, which you'll hear about from Gail, and alarm therapy. You'll hear the word urotherapy. I think Arnie's going to talk a little bit more about that, but basically it's conservative therapy for lower urinary tract dysfunction. So standard is education, behaviour modification for voiding and bowels, fluid and diet advice, and then there are specific things you can add, such as biofeedback, neuromodulation, intermittent catheterisation, although I don't know that that's conservative, cognitive behaviour therapy and psychotherapy. This is ICCS definition. I don't claim anything from this. So treatment outcomes, it's really good to know, like, when are you measuring your outcomes so that you're actually all measuring the same thing. So initial success. They talk about complete responses, like completely dry. So that's what you want, a complete response. A partial response is they're better by 50 to 99% reduction in their wetting compared with baseline. And a non-response, so less than 50% reduction, is considered not a response at all. So how long is success important for? So long-term success after you completely stop treatment. Relapses, if you get one symptom, more than one symptom per month, then that's a sign of relapse. If you have no relapse in 6 months, then that's called continued success. And if you've had no relapse in 2 years, that's called complete success. So we often get kids dry, but they often relapse. So it's good to know these definitions. So often kids might relapse a little bit, but it's still a relapse. So it's just important to know those terms. Okay, so I've finished my talk now.